Then we're so pleased today to have Dr. Uberti with us. He's a specialist in medical hematology and co-director of the bone marrow transplant program at Barber and Carmanos Cancer Institute. He's actively involved in clinical research in bone marrow peripheral blood stem cell transplants and is the expert to answer your questions about transplants as part of a treatment protocol for multiple myeloma patients. I'm really happy to have Dr. Uberti here. He really certainly is one of the experts in this field, and he's the man at Carmanos. So I want to also say thank you to our sponsors, Adaptive Biotechnologies and GSK. Without them, we wouldn't be able to bring this format to you. So with that, what we're going to do is open up the chat for questions. Dr. Uberti will tell you a little bit about himself first, and then I know Sid had a couple questions to kick things off. So we'll let Dr. Uberti talk just for a couple minutes about what he's doing, what he finds interesting right now, a little bit about himself, and then Sid will ask a couple questions, and then hopefully that'll get everything rolling, and we'll just have a nice conversation.
So well, thank you very much, Michelle. Thank you for inviting me, and good afternoon or good morning to everybody out there. Just a little bit about what I do here. So I'm head of the hematology portion of the Carmanos Cancer Center. So that includes stem cell transplant, leukemias, lymphomas, all the benign hematology. And within our transplant program, not only do we do the stem cell transplants, but we also do the CAR T cells. So we have available now the CAR T cells for multiple myeloma, which we're doing. They've been FDA approved recently. There's 2 different products out there. We're the only place in the state that has both products available to us at present. And we do a lot of transplants for multiple myeloma. So most of our time in terms of multiple myeloma has been involved in either doing transplants for multiple myeloma and or doing CAR T cell infusions for multiple myeloma, which 2 products have been FDA approved within the last year. So we have those available here. It's a bit of a waiting list to get onto those product websites, but we can go over that in a little bit. Just a little bit more of my background. I kind of grew up in Detroit, went to Detroit's public schools. In spite of all that, I made it through and finally became a doctor somewhere along the line. And I've been at Carmanos now since 2004, directing the transplant program and the hematology program here at Carmanos. So I'm very happy to be here. I participated in this types of forum for the last few years, mostly talking about transplant and CAR T cell. You know, we get referred in a lot of patients from many of your hematologists, oncologists, physicians who need transplants or need CAR T cell evaluations, which we do on a daily basis here at Carmanos. So with that introduction, I'd be happy to answer other questions, and let's start the discussion.
Can you hear me, Dr. Kamar?
Very well, Sid.
Oh, good. How are you?
Good. How are you, Sid?
Good. Thanks for joining us. First question I would have is the role of stem cell transplants. Has that changed a lot in the last 12, 15 years?
You know, Sid, I really don't think so. It's still the recommendation for most of our patients to go through transplant as part of the standard therapy for multiple myeloma. So usually what our recommendations are, and all the societies, all the myeloma societies make the same recommendation as part of upfront therapy for multiple myeloma. So what I mean by that is patients usually go through induction chemotherapy with whatever regimen there are. As you know, as many of you know out there, you know, the standard regimens have been for a while Revlimid, Velcade, and dexamethasone. And now more and more patients are getting 4-drug regimens, usually with the addition of daratumumab, along with Revlimid, Velcade, and dexamethasone and daratumumab, or sometimes Kyprolis and Revlimid, Decadron, and daratumumab. Those are very common 4-drug regimens. We're seeing more and more patients be started with, at least initially. And we usually make the recommendation of transplant to be done after 4 to 6 months of those therapies. And what transplants has done in all these studies is increase the time the myeloma stays under control. So it's not a cure for myeloma, but it does seem to prevent the progression of the myeloma compared to standard therapies we have available to us. And what's the advantage of that? The advantage of that is that hopefully we will find a cure one day for multiple myeloma. What we want to do is prevent the progression of the disease as much as possible until we do find a cure. And transplant appears still to be the most effective way of doing that. You know, some of the more recent trials looking at chemotherapy or the RVD regimens or the 4-drug regimens followed by transplant has shown that the transplant added to those regimens really increase the depth of the response, really increase the amount of patients who have MRD negativity. So really still play an effective role in the treatment of patients with multiple myeloma. So I think it still remains at the forefront of treatment for multiple myeloma. So number one disease we do transplant for here at our center. We do about 110 to 120 a year. So number one disease transplants are done around the United States and around the world. And those numbers are still going up on a yearly basis.
Amazing. Is it shown to increase lifespan of patients?
Well, it hasn't done that. So it seems like the overall survival in patients who go through transplant versus, you know, let's say an early versus delayed transplant, it hasn't done that yet. But I think it's part of all the therapies we give that increase lifespan of patients with multiple myeloma. You know, it's a very effective therapy. It works by a different type of mechanism than our standard therapies we use for multiple myeloma. So it's able to eliminate some cells that have become resistant to some of the standard therapies. So I think all the therapies we put together for multiple myeloma have increased the lifespan. Transplant is very effective. It does not increase the overall survival when in the randomized trials as compared to standard therapy, but it does help prevent the disease from coming back. That is a relapse-free survival more so than the overall survival. So as you know, the survival of patients with multiple myeloma are increasing on a yearly basis. So we're living much longer than they ever have in the past. And I think it's a combination of all the therapies we do. The transplant, the Velcade, Kyprolis, Darzalex, so many drugs are used together in combinations, and now CAR T cells, which have just increased the ability to keep patients with multiple myeloma alive for a much longer period than we've ever had in the past.
Just one more question for me. When I had mine about 15 years ago, and my doctor now wanted to suggest I have another one. At that point, 15 years ago, I think 60 was like the age where you stopped giving them. Has that changed a great deal, or is that still?
We've gone up to patients as high as 80 years of age for transplant myeloma.
Okay.
And the data comparing what older patients are these days, 70 to 80 versus 60 to 70, looks to indicate that the outcomes are about the same. I mean, I have to caution you, obviously there are some patients who are 75 or 80 who are very poor shape. We would not recommend a transplant on. But the patients we do bring to transplant who are in fairly good shape do just as well as younger patients who go through transplant. So we've looked at this in a lot of different studies. So we try to evaluate patients as they come in who are older, you know, in their upper 70s, early 80s, and decide whether or not they may be transplant candidates based on their other risk factors. Do they have heart disease, lung disease, kidney disease? We have to take all those things into account. And just how active they are. You know, I often just ask a patient, how far can you walk? Can you walk up and down stairs at your house? Can you walk in from the parking lot to see us? Are you bedbound? I think those are the criteria we look at more so than age these days as who can undergo a transplant. And even CAR T cells, which does require, you know, a hospitalization associated with it. There are toxicities associated with it. So all those things we try to take into account when we make recommendations, usually using cellular therapy.
Thank you.
So anyone else, you can either unmute or put questions in the chat. I don't have any questions in the chat yet. So it would be nice if we did have a few so we can keep the conversation going. I think that this is really interesting. Yes, Hal?
I think I heard last week that sometimes stored stem cells are sometimes used to rescue patients who have had a CAR T cell procedure. And have you done that there at Karmanos?
We haven't rescued too many patients after a CAR T cell procedure with stem cells. That we haven't done so much. So I don't know what the data is on that particular sequence of events. We do use stored stem cells for second transplants we do use stored stem cells for patients whose marrows have been beat up so much by the chemotherapy to kind of reestablish their normal hematopoiesis. We haven't, I don't think we've done one yet where we've done a stem cell transplant after patients gone through CAR T cell therapy. I don't think it's an unreasonable thing to think about, but we haven't done one in that sequence of events.
I have a related question. We've been storing my grandson's cord blood cells for 19 years now. And do you see any potential use for those, or should we just stop paying the storage on those?
So that's a little bit of a controversial issue. I'll tell you what our bias is, that we shouldn't be storing those cells because the chance of using them are very low. And we don't know how effectively those cord blood cells were actually harvested at the time of the birth. So there's quality issues on those cord blood stem cells that we can't evaluate. There are very little data that suggests those are a viable option for patients who may need one in the future. Now, we have national cord blood banks where people can donate their cord blood to anybody who may need a transplant. But those national cord blood banks, which we have one here at Carmanos, have very rigorous standards on what cord bloods we take, how we evaluate the activity of those cord bloods, and whether or not they have the appropriate number of stem cells. So there's different thoughts on that a little bit. So we don't encourage that actually. If people want to donate their cord blood to somebody who may need a transplant, we encourage people to store them in the registries rather than for individual use.
Thank you.
A couple of questions in the chat. Judy Brown asked, when is CAR T cells recommended?
That's a good question. I was going to bring that subject up. So currently the FDA has approved two CAR T cells, and the recommendation of when they can be used is identical. And basically what it recommends, well, the FDA only recommends the use of CAR T cells after you failed 4 therapies. So what do 4 therapies mean? Just to give you an example, when you go through a transplant, the RVD and the transplant and maintenance therapy is considered one therapy. So to go through CAR T cells, you have to fail something like a transplant plus 3 other agents, Kyprolis, Darzalex, selinexor, 3 additional agents after the transplant, as an example, are what the requirements are based on the FDA recommendations. Doesn't have to be a transplant as one of the regimens, but I'm just giving an example of how we have to count those regimens. And even in spite of that, some of this outcome has been very good with CAR T cells, even in patients who fail 4 regimens. The most recent CAR T cell that was approved just a few months ago, this is patients who failed 5 different regimens. And about 96–97% of patients responded to the CAR T cells. And about 50 or 60% of those patients actually developed a stringent CR, which is quite remarkable after all the therapy they've received. So the CAR T cells have proven to be fairly effective at getting the disease under control. Now, how long that lasts is a little bit disappointing. We were hoping it would last for years and years and years. And it depends which CAR T cell you look at. Some of them last for an average of maybe a year, year and a half. The other ones averaging maybe out 2 years now too. So we need to have a little more experience as to where it's going to fall and how long this keeps the myeloma under control. But at least there's some initial encouraging results that they can cause a very deep response in patients with multiple myeloma. So what we hope happens to the CAR T cell story is that we move it up closer to the time of when you go through all these therapies. Instead of failing 4 therapies, we'd like to see it used after you fail perhaps 1 or 2 therapies and see if we can get a better response in that situation. Because myeloma cells, like all cancer cells, are pretty smart cells. They learn to become refractory to all our therapy. And although you respond very well when you use it after 4 CAR T cells after 4 lines of therapy, maybe the response will be much better if we use it after 2 lines of therapy or further up the chain of all the therapies patients with myeloma get. So we're hoping we're moving forward in that direction.
Second question, this is from Mary Narat. What are the two types of CAR T available at Carmanos?
So they have all kind of funny names. One's called a Abecma and one's called Citracell. There are only two available right now. They're both available here. So the problem with it is their waiting list to get on either of these CAR T cells. So the manufacturing, the places that manufacturing, the two companies that manufacturing it have manufacturing inadequacies. They can't make enough for all the people who need them. So they're both available here, but we have to put patients on a waiting list because we get about 3 slots a month right now for patients who need CAR T cells. And until they can open up the manufacturing more, until they get more facilities that can manufacture these cells, that's what we're limited to. So right now we have a waiting list of about 20, 25 patients who we've already evaluated for CAR T cells, who are eligible for CAR T cells, who've gone through all the insurance approvals, waiting to get CAR T cells. So why is the manufacturing so hard? They're giving us various explanations. It's supply chain issues, just like everybody else tells you when things slow down. They can't get the vectors to make the CAR T cells. They don't have enough this reagent, that reagent. Hopefully it'll get better in the future, but that's what's happening right now in the manufacturing of CAR T cells. There's some delay in the manufacturing process.
Does anyone else have a question here? I don't see any more in the chat so
Michelle?
Yeah, Sid.
There's a CAR T cell being manufactured in Israel right now. Are you aware of that? How valid is it?
I don't know the actual data on that. Said there's a lot of CAR T cells being manufactured in different countries.
I see. Okay.
So we had investigational trials with some of them, but we don't have any investigational trials open with the ones from different countries.
The data I saw on it was very, very positive, and it's a lot less expensive than the existing CAR T cells.
So
what does it cost now? What does it cost to get a CAR T cell?
Well, the cost of us to buy the CAR T cells varies between $450,000 and $500,000. So it's a pretty expensive proposition. And that doesn't include all the other things as part of the supportive care we have to do with CAR T cell patient. Because to get a CAR T cell, you need 3 days of mild chemotherapy. Then you have a hospitalization after you receive the CAR T cells for at least a week, where some of the complications occur. So the cost of getting CAR T cells is $700,000, $800,000, $900,000 when we put everything together. And one of the difficulties we're having is that Medicare has decided not to reimburse us very well for this. So as an example, if we buy a CAR T cell for $450,000, Medicare sometimes reimburses us less than $200,000 just for that part of it. So, we start losing $200,000 in every administration of CAR T cell, we're not going to be in business for a long time. So it's always a negotiation between Medicare, their supplemental insurance of what we can do with these situations. So it's I think a tragedy that they're charging so much for these CAR T cells, quite frankly. It's been estimated to make these CAR T cells, it costs about $15,000 to $20,000. And they're charging us that much more to buy them from them. Now, I understand they have to recoup their research costs and all that, but this does seem a bit extreme.
Here's a question from Jerry. What criteria do you use to put people on your waiting list? I'm assuming for the CAR T cells. What determines the priority?
So that's a good question. So first of all, we have to make sure the patient has met the criteria of failing 4 therapies. So that's the first thing. And then we try to see how quickly or not so quickly the patient needs to go. So we're trying to use kind of a risk-adapted score to see, does a patient need to go right away? Are they failing therapies? Are they having a lot of complications? Or they can wait a bit, or can they wait a bit? So we're trying to use that to try to make it fair as possible to all the patients, which is very difficult at times, as you might expect. Patients don't want to wait appropriately. So, why can't I get this therapy? What's causing this delay? So we try to base it on some of the risks the patient has in terms of their underlying disease.
Here's another question. If people are willing to pay the difference between the cost and Medicare, does that make them more of a priority?
Well, I don't think we could do it that way, quite frankly. We have to do it by kind of other criteria. Certainly we don't ever refuse somebody because that we don't get reimbursement. We try to find a way to make the reimbursement work. So we try to do our best to get what we can to make this at least a break-even proposition for us as we bring our patients through transplant.
So I have a question related to that. What if a patient is younger and isn't on Medicare yet, but has their own insurance, like through their place of work or wherever? Do most other insurances cover this? Is it just
Yeah.
Medicare that gives you a problem?
So most private insurances do cover it much more effectively than Medicare does. Medicare has a hard time to figure out how much to pay for these things. It's a long process. And I think they're getting better at it. I think the reimbursement is improving, but still it's a tough battle for us every time a patient Medicare comes in for a CAR T-cell evaluation. In terms of a transplant, as an example, costs maybe $50,000 to $100,000. When a CAR T-cell, we're talking about $700,000 to $800,000 is the total cost when you put everything together. For some of the non-myeloma CAR T-cells, some of those we could do as an outpatient, which it makes it a little bit easier for us to get reimbursed. For the myeloma stem cell, for the myeloma CAR T-cells, we have to do that as an inpatient. And that increases the cost quite a bit for us.
Any other questions from the group here? You can just unmute and ask too, or you can put it in the chat.
What is the quality of life after a CAR T cell transplant? I mean, I know that could be different for everybody, but are you also off of chemo treatment once you've had the transplant?
So it's a little bit different. After transplant, let me just take transplant and CAR T cells separately. After transplant, we usually recommend maintenance therapy. So what that means varies from patient to patient. Maintenance therapy has usually been to start Revlimid at a low dose, usually 10 milligrams, at about 100 days post-transplant. Now there's different criteria we use for maintenance therapy, so it's changed a bit. But it's usually lower doses of chemotherapy that you stay on, such as Revlimid, sometimes Velcade, sometimes Darzalex, at a dose that doesn't cause a lot of toxicity, but does prevent the myeloma from coming back. So almost all of our patients who go through transplant do go on maintenance therapy because it does seem to improve how long the myeloma is under control. For CAR T cells, usually as you go through CAR T cells, there's no maintenance therapy given after that. And you stay off therapy until there's evidence of the myeloma coming back or progressing. So the recovery after stem cell transplant usually takes about a month or two. The recovery after CAR T cell usually takes about a month or two as well. There are different toxicities. Probably the biggest difference of toxicity is some of the neurologic toxicities that's unique to CAR T cells. For reasons we're not exactly sure of, when you get CAR T cells, and this doesn't matter whether you get CAR T cells from myeloma or lymphoma or any of the other diseases, there can be a significant neurologic toxicity that develops even up to 8 weeks after we give the CAR T cells. And that can include things like difficulty speaking, confusion, even we've had seizures that patients develop after CAR T cells. So that's a little bit different than the standard complications we get after stem cell transplant. So there are differences in the recovery period a little bit, differences in whether or not you get therapy after the procedure. CAR T cells, we usually don't give therapy after in terms of maintenance therapy. Transplant, we usually give maintenance therapy afterwards.
Okay. Judy just had to leave, but she says that she's going to watch the recording because this is so interesting. So thank you for that, Judy. Anyone else want to unmute and just talk about this? Last time we had a little bit of a nice conversation prior to the to Dr. Margolis joining just between patients. So let's open it up and just ask your questions for Dr. Uberti. He's here for you right now.
How long are you inpatient after a CAR T cell transplant?
It's usually at least 7 days. So what happens is that you get some mild chemotherapy. Let's just say we give the mild chemotherapy. It's usually 3 days on Wednesday, Thursday, and Friday as an outpatient. We admit you on Monday, and we usually infuse the CAR T cells on Monday. And the infusion of the CAR T cells, it looks like a little cup of water, goes in about 10 minutes in an IV into a vein. And we usually keep you in the hospital for about 7 days. And that varies a little bit from patient to patient, depending on whether or not you develop some of the well-known complications to CAR T cells. With the first 3 or 4 days of a CAR T cell infusion, you get something called cytokine release syndrome, which we abbreviate CRS. And what that is, that when we give you these CAR T cells, they expand and start killing off your tumor cells, your myeloma cells. And when they do that, they release a lot of small molecules into the circulation that can cause fevers, it can cause low blood pressure, it can cause low oxygen levels in your blood. And so it's something that we see a fair amount of time after the administration of CAR T cells. And there's medications we use to treat that. The most common one we use is a drug called tocilizumab. And that's administered IV in the hospital. And that usually treats some of those complications you get. And that occurs about 3 or 4 days after we infuse the CAR T cells. The other thing that happens, that neurologic toxicity, happens a little bit later, further on down the line after the CAR T cells, let's say 8 to 10 days after we infuse the cells. That may be a little bit more difficult to treat because we're not as sure what really causes that manifestation of the CAR T cells. But it does require sometimes a prolonged hospitalization. The third thing that happens after CAR T cells, your counts do remain low for a fair amount of time. So it means you have some risk of infection, just like after a stem cell transplant. And sometimes it takes a little bit longer time for the cells to recover. So your counts do go lower to the point where you may need transfusions of blood and platelets. You may become infected. And it is one of the things we see after the infusion of CAR T cells. But generally, we tell our patients it's going to be around 7-day hospitalization after the CAR T cell infusion, especially the one for multiple myeloma.
What is the difference between the outpatient CAR T procedure and inpatient? One person I know from another support group at Carmanas has multiple myeloma, and she was having an outpatient CAR T cell procedure. So what does that mean in comparison to the one you just described?
Most of our myelomas we do inpatient. I don't remember that one being done as an outpatient unless it was under one of the clinical trials. We do outpatient CAR T cells for some of the other diseases, but right now for multiple myeloma, they're recommending the patient is inpatient after we give the CAR T cells. So I don't know which one that maybe she went through, but I'm pretty sure most of them have been inpatients. So I am surprised. We might have done one as a outpatient for some extenuated circumstances, but that's not our usual recommendation. And that's the recommendation of the company that makes it. And it's the recommendation of the FDA as well. So that might have been some extenuating circumstances in that patient. I don't remember.
Here is a question. Is there research on CAR T that targets BCMA plus other receptor sites on the MM cells?
Right, so there is research going on targeting multiple receptors. The BCMA, which stands for B cell maturation antigen, is a target for the two CAR T cells that are approved through the FDA for administration. And it's the way most CAR T cells are made. They want to target some of the antigens as cell proteins on the surface of the tumor cells. So they try to look at multiple targets, and there's a lot of them that are being looked at. None of them have been brought up to be approved through the FDA, but there are quite a few investigational trials looking at multiple targetings using CAR T cells.
This is one changing the subject a little bit. Um, uh, where do you see COVID infections going in the near future?
That's a good, we just spent an hour talking about COVID infections in one of our other meetings. So it seems like COVID infections are going to be with us for a long time. I think it's going to be a chronic viral infection that we're going to gather more information of. I think we're going to continue to use immunizations probably for the next few years at least to keep COVID infections under control. You know, we currently recommend all our patients get COVID vaccines. We're recommending 4 and sometimes 5 vaccines as an example right now for all of our patients. We have pretty good therapies that we haven't had before to treat patients when they get COVID. There's a new oral medication now called Paxlovid, which you take for 5 days, which decreases the hospitalization of COVID infections by about 80%. There's some IV antibodies that we now use. The one we're using to prevent COVID infection is called Evusheld, and that's given as a shot. And it's an antibody that lasts for about 3 to 6 months that can prevent COVID infections. So COVID is with us. You know, the numbers are going up in the Tri-County area in Michigan and all over Michigan right now. It's probably going up more than we think because more and more patients are just using in-home kits to get tested, and that's not reported to the agencies that report how many COVID infections we have. But I think it's going to be with us for a long time. I think we urge people to get vaccinated. We urge people to use caution. We urge patients to notify your physician if you do develop COVID because we have some nice new medications for it to treat it. So I think that's what we're going to have to proceed forward with in the future.
Regarding that Evusheld, we spoke about that with some in a couple of these other sessions. Is there a recommendation on? I know that that there was one of the sessions. There was a recommendation as to the timing of getting that between your vaccinations. Do you have any thought on that?
So it's a little bit controversial how to give it and when to give it with vaccine. So you can't give it right away after you get a vaccine. So you're supposed to wait a week or two after you get it to get the Evusheld. And Evusheld is 2 different antibodies that target the spike proteins on the COVID viral particle. And it's given as a shot in both sides of your butt. We usually give it at the same time. So we give it to most of our patients who go through transplant, to go through CAR T cell therapy. Sometimes we give it before the transplant or CAR T cells. Sometimes we give it after the transplant. But we generally try to use it in conjunction with vaccines. So as an example, once you go through CAR T cell therapy or transplant, at around day 30, we give you Evusheld to protect you during that time period. And then we start your vaccines at 100 days post-transplant because everybody gets vaccinated after a transplant. In some of our situations, we give Evusheld before they come in for CAR T cells or transplant, even if they've been vaccinated. The concept is to give it to patients who you think will not respond well to vaccines or patients who haven't been vaccinated. In spite of what the recommendations are, we give it to patients who have been vaccinated. And so it's a little hazy of where you give it right now.
I know we're always learning as this pandemic progresses. Seems like it's always changing.
Yeah.
Another question, same kind of thought process. If you feel you might have COVID, should your first contact be your PCP or your myeloma doctor?
Well, first you should prove you have COVID. So I think the first thing is to get a test. If you're positive, then you could contact either one because you should get Paxlovid. You should get the oral medication. So if you have any sort of cancer, you're eligible to get it. It can go through your primary care doctor. It could be through your myeloma doctor. It's a little bit cumbersome. We do it all the time. We have to fill out a form. We have to send it to a pharmacy. Not every pharmacy has it, but we try to send it to a pharmacy that's close to where you live, so it's easy to pick up. It's an oral medication. You take it for 5 days. It's pretty good at preventing it from becoming more serious. The most common side effect I think people have of taking this oral medication is it causes a metallic taste in their mouth. So that's the thing we hear most often. But either your primary care doctor or your myeloma doctor can take care of doing that. primary care doctors probably haven't given it as much as we have, because we give it to everybody who's gotten an infection from COVID because they meet the criteria. You know, if you're a healthy young adult, as an example, and you have COVID, you don't usually meet the criteria of getting this oral medication.
Paclomed, can you spell that so that,
It's I'm the worst speller in the world.
okay, so maybe I'll just,
Let me just look it up so I
Yeah.
don't do the wrong spelling.
did I say it right? Paclomed?
It's Paxlovid, P-A-X
Okay.
L-O-V-I-D.
V-I-D, Paclomed. Okay, I'll look it up. Okay,
That's how you spell it.
okay.
So it works, you know, realize that people who are vaccinated get COVID, you know, vaccines aren't 100% protective, but hopefully they're preventing people from getting very sick from COVID, even if they get it. And Paxlovid, on top of that, in patients who have cancer, will prevent it from even having causing more problems. But we've given it to over many, many people. But you have to have a positive test. So either the home test can be positive or the PCR test.
I have a question about the immunizations. I delayed, I didn't get them after the stem cell transplant in June of, or May of 2019.
Mhm.
I was just wanted to, I sometimes get questionable reactions to things. So I just wanted to delay them, but then COVID came along and I was afraid to take those in that environment. And now it's this long after, and I got all my COVID shots. I got the pneumonia and the flu and maybe a couple others, but I didn't get the baby ones. I did not. Is it okay to get them at this point?
Which baby ones are you talking about? There's measles, mumps, rubella.
MMRs and all of that.
So, you know, the MMRs are attenuated viruses. The other vaccines are dead viruses. So the MMRs are a little bit touchy, but you usually can get them. Now, you should probably check with your myeloma doctor and see about that, because some have strong feelings one way or another. But we do vaccinate our patients, as an example, go through transplant 2 years with the MMR vaccine. They can get it.
Okay.
But check with your doctor who's ever taken care of you and see what they think.
Yeah, you mean 2 years, 2 years?
You're breaking up a little bit. 2 years after the transplant, we do recommend the MMR vaccine.
Oh, okay. Okay. All right. Thank you.
You know, I think the good news is for multiple myeloma, although we don't have a cure, every year we have more and more medicines that work with it, more and more medicines that keep the disease under control, prevent some of the complications. You know, we haven't gotten a cure yet, but we certainly have allowed people to live longer, prevent some of the complications of multiple myeloma. And that's a good thing about multiple myeloma right now. You know, before people, 15, 20 years ago, we didn't have all the medications we had, and people would live maybe 2-3 years with multiple myeloma. Now people are living 10, 15, 20 years with multiple myeloma. So it's really been a tremendous benefit, I think, with all the new medicines that have come out and all the new procedures. And I think we will have a cure over time. We haven't got there yet, but I think every year we get a little bit closer.
So a few years ago, when we first started these conversations, the CAR T was something that doctors were really excited about because it looked like it could potentially lead to a cure. Do you think that it might still?
I think it might. Remember, I think we're using it very late in the disease. And I think what'd be interesting to find out is that if we use it earlier in the disease course, we'll have a better longevity. Is it going to last longer if we use it earlier in the disease course? You know, we use it so late in the disease course now that patients are debilitated. Their myeloma has become more and more resistant to all the therapies we use. And it might be a little bit more effective. We use it more early in the disease course. So that's what I hope, that the research proceeds forward in that we could use a little bit earlier. You know, and now there's, with the 4 drug regimens becoming more and more available, they clearly have an effect of giving people deeper responses. And now the new thing we look at is MRD negativity. That is, by the most sensitive test, we find out that many patients don't have any of the evidence of myeloma in their bone marrow after they go through some of these 4 drug regimens, after they go through a transplant, after they go sometimes through CAR T cells. We've gotten down to very low levels of myeloma in the bone marrow, far lower than we've ever been able to show before. So I think we will somehow get there, to get that really have no myeloma cells left in our patients. I think somebody asked whether the MMR vaccine, if the patient is on Darzalex or Pomalyst, U of M won't give it. You know, there's always a risk. Those are live attenuated viruses. And some people worry that they'll cause the disease rather than give you an immune response, or may not even give you an immune response. So there are different situations for all of those, the administration of all those vaccines. So they might not want to give them in certain situations, depending on what medications you're taking.
Doctor, is there any truth at all to the few medical people and lots of other people that say you get inflammation or you get a reaction from your immune system from the COVID vaccine that can cause you to have an autoimmune disease? I have temporal arteritis right now, and nobody knows what causes it, evidently. I have had my 2 vaccines. I had to wait for the booster because of that. High steroids, that's what I started. So I'm down to 6 milligrams now after about a year.
So, you know, there have been some reported cases of an autoimmune disease after many of the vaccines we use, including COVID, but it's a very, very low incidence of that. So they're looking at this. You know, that has been reported, but it's a very low rate compared to everything else we do to our patients. You know, and everybody compares getting the vaccine to getting COVID. And certainly the complications of getting COVID are far, far greater than the complications of whatever vaccine you get. Certainly there are side effects of all vaccines we take, but they're at such a low level and they appear to be so safe. We don't think that's much of a reason not to take it.
Okay, thank you.
Is there a simplified explanation of why can't we cure multiple myeloma? Why can't we cure about it right now?
I think the reason is that we haven't found a way to absolutely kill off the original cell that's causing the myeloma. If you think about it, we talk about cancer, what's called cancer stem cells. So cancer stem cells are the cell that really originated and caused the myeloma. And from that cancer stem cell, you get all the other cells from the myeloma that circulate through your body. So we're very good at killing off all those other cells that circulate through your body. We haven't been able to find a way to kill off that one cancer stem cell that really originated the disease. So that really, and it's hard to identify that cell, and it's hard to find a way to really target that cell. So we've been able to target all the progeny of that cell pretty well, but I think we've been unable to target as well the cancer stem cell that started this whole horrible disease. So I think that's the simplest explanation I can give. And you know, all of our cancers are caused by genetic mutations in our body that occur in all of us as we age. And somehow those genetic mutations that cause this type of B cell or plasma cell to develop into a myeloma has made it very resistant in that stem cell population to all the therapy that is very good at killing the progeny of the cell, but not so good at killing the cell that's really causing all this damage to occur. So that's the simplest explanation I can give. You know, if I found out the answer to that, I could win the Nobel Prize, but we'll keep looking.
Well, thank you for the simple explanation.
Well, that's very interesting that you talk about it being genetic rather than environmental or something we do. Does that mean that something triggers myeloma to start, but it was kind of like you think of the something being dormant in your body, and then because of circumstances or environmental things, that it all of a sudden starts.
So I want to make a distinction between two types of things. Some things we're inherited with. Sometimes we get mutations that we come as soon as we're born. Myeloma is a type of disease that we thought we acquire as we age. So all of us as we age get more and more genetic mutations. It's part of life. As we get older, and if we look at this, we just develop genetic mutations. We're not born with these. We're not born with most of them. But as we age, it's part of aging that we develop these mutations. And it's part of everything. With environmental factors we're exposed to, as part of the aging process, all those things contribute to this accumulation of genetic mutations. Some of them don't cause anything. Sometimes we have repair mechanisms within our body can get rid of these genetic mutations, but sometimes we don't. So these are called acquired mutations as we age. And that probably causes 90 to 95%, if not more, of all cancers. It's part of our life cycle that our DNA goes through changes, it goes through mismatches, it goes through translocations, which we have mechanisms to eliminate those changes, but sometimes those mechanisms fail. And as we just collect more and more of these mutations, the chances of us getting any sort of cancer actually go up as we age, because we've seen that over time, these genetic mutations just accumulate in our bodies over time. And it's part of all the things that happen to us. Smoking causes environmental exposure, exposure to sunlight, exposure to all the toxins in our environment that we're surrounded with, all somehow play a role in developing those genetic mutations.
Thank you so much. That's very helpful.
It is. Do you know why multiple myeloma is more prevalent in some groups of people than in others?
So that's another tough question to answer. It is, the African Americans have a higher incidence of multiple myeloma as an example. I don't think anybody, I could be wrong about this, but I don't think anybody knows yet why that is. So it'll take a little bit more research to sort that out. I don't know if I could give you an easy answer, or I'd hate to say something that's wrong if people know more about it than I do, which I'm sure there are people who do.
And it seems to be more of a male disease than female. Is that?
Yeah, that's true as well. Again, all these cancers develop as we age. The average age of people with multiple myeloma right now is 69 or so, or 70.
Oh.
It's a disease of aging. It's a disease of certain ethnic populations. It probably has a male-female predominance, but how to put those all together to give a coherent picture of it is a little bit hard, I think, at this point. And I don't think I can even attempt to do that.
Anyone else?
I have a translocation of 414. And is there anything specific that's in the works, or that is the CAR T it's specific for it, or that is there anything out there at this point?
There have been some drugs for multiple myeloma that have been targeting certain translocations. Probably the most common one, people with the 11-14 translocation, that's not uncommon in multiple myeloma, can be targeted by venetoclax. For your specific translocation, I don't think yet we've identified a molecule that can target it. We've seen when we do CAR T-cell infusions or even stem cell transplant, we can eliminate all those translocations. That is part of the genetic mutation profile for patients with myeloma. So they can be eliminated. Unfortunately, they come back. So they're targeted along with everything effectively, but they usually can come back. CAR T cells get rid of it. Stem cell transplant gets rid of it. Standard chemotherapy can get rid of those mutations as well. But I think the only one of those that's been targeted is the 1114 translocation.
Thank you.
Are there currently any trials for using CAR T cells? Like you were saying it earlier, like after 2 failed therapies, or is that not happening yet?
It's not happening yet. I'm sure the companies are looking at ways to move it up earlier. I suspect what's going to happen in the future is CAR T cells will be used in conjunction with stem cell transplant, actually. I think that's where CAR T cells are going to be going, because the stem cell transplant seems to give you the greatest improvement of getting rid of myeloma cells. And then if we add CAR T cells to that, that may be the way in the future in how to give us perhaps a chance of cure with this underlying disease. So I suspect companies are developing protocols looking at that combination of therapy. How can we use one plus the other, perhaps to give us a better response than we've ever had before in terms of these diseases?
Would you do that both at the same time, like in one procedure?
No, you would do them consecutively. I'm just, go through a transplant or CAR T cell, then follow that up after you recovered completely with a CAR T cell infusion or transplant. You can't add them together because the toxicities would be too difficult. So they're different toxicities, but if you add them together, there'll be cumulative toxicities, which patients would have a tough time with.
Yeah.
Is there anything new in maintenance that would apply to someone who survival rate, the doctor would be worse with transplant than without? And so he is 83 and he is currently on Pomalyst, 21 days, Dex 1 day, elotuzumab and Dex from an infusion for the 4th week. And they've left him on it for 2 years. And then because of his age and COVID and everything, I think it was 2 years in January. And since it's just kind of keeping him stable and working the best, they've kept him on it. But I don't know what would be, next.
So it's hard to know. I can't give you an exact answer for that. That's as maintenance therapy, that's almost like treatment he's getting with all those medications. So, we would hope.
No, I mean, that's what they have delayed maintenance because the numbers kind of change a little bit. And that's the only thing Velcade and Ninlaro and all those things that he's had was a short time. And they only started him on Rev and Dex when he began, just the 2, about 6 years ago. So he's had several different ones, and this is the only one that really has gotten him down to a good level. So I don't know if there's a regular maintenance or if everybody differs with maintenance when they feel they can drop back.
So it's a little bit different for the situation you're describing. I think it's kind of nobody has a direct idea of what to do in that situation. That might be a little bit of a trial and error.
Okay.
They might try dropping something, maybe something that's causing more side effects, and seeing if the other drugs keep things under control. Because when you do maintenance therapy, you always try to look at what's the least I can do that causes side effects, but keep the myeloma under control. So if it's 1 drug or 2 drugs, if you can get by on 1 drug, you prefer that over 2 drugs, just because there's more toxicity with 2 drugs. Which is the right combination is a little bit harder to identify with any of the criteria we use right now. So sometimes it's trial and error. They might want to try stopping one of the drugs and see what happens. If he has a lot of toxicity, it makes it a little bit easier to choose a drug which is causing more toxicity. With that type of therapy he's on, I don't think there's a lot of concrete studies that would tell us which way to go with that.
That's what I was wondering. He has a lot of neuropathy, but he also has diabetes. So some of that is from that. And he's just really getting tired now and not feeling good. And his numbers are not horrible at all, like they had been. So, it could be some of his other, like I say, the diabetes or the neuropathy. They've very regularly lowered his doses of both Dex and Pom because of neuropathy. And So I guess we just can't tell if it's the ELO or the POM or what really is helping the most or the combination. Is that correct?
That's correct. It's a hard thing to sort that out. And what drives the changes are sometimes the toxicity more than anything. If you
Okay.
get severe neuropathy or something else from some of the medications, I mean, if you can identify which drug is causing that complication, that's the one you probably try to decrease first to see if that can still provide effective regimen without the excess toxicity. Because those can
Right.
be pretty debilitating, neuropathy. It's not an easy disease sometimes for patients to go through. And that can be pretty miserable.
Yeah.
So you try to pick the one that may be causing the most toxicity, cutting back on that and seeing if things can still stay under control.
Okay. So it is really trial and error. Thank you.
Yeah.
You have so many drugs now and so many combinations that you can use that I think it'd be hard as a doctor.
That is really true. Yes, yes, yes. There are many combinations, many new drugs, many new combinations we can use. So, it's a bit of trial and error with those sort of situations, especially as people have been through more and more therapy and they've been through a lot of different therapies.
Mhm. Well, the doctor did say the encouraging thing was that there are so many things to try. She was thinking maybe some of his other things would cause his survival to cease. He would die more likely from something other than myeloma. So she was encouraged by all the new myeloma drugs and possibilities.
Yeah,
But
absolutely.
we have lost people in the support group because their body just wore out by the time we're going to get CAR-T, and they just, had heart problems and other things. And so, like you were saying, sometimes you're not capable of getting those things.
That's true.
Your body can't tolerate it.
That's absolutely true. I mean, these aren't simple procedures to go through. It does take a bit of, we have to have somebody who's got a fairly reasonable performance status to get through this safely. So we don't obviously want to make things worse with any of the things we do. With all these procedures, just as an example, all of our patients have a tendency to get weaker. And if somebody who comes in weak undergoes CAR-T cell therapy or stem cell transplant therapy, chances are they'll be weaker by the time they get out of the hospital, which makes the recovery. I mean, none of us are 20 years old anymore. All of us are going up in age, which is good, but it makes recovery from all these things a bit more difficult. And boy, when we add some hospitalizations on it, people lose their performance status, they lose their exercise tolerance very quickly with these longer hospitalizations that are required for some of these therapies.
Thank you so much for staying in the field and helping us. We appreciate you people who are dedicating your time to that.
Well, thank you. We're trying to do our best and try to do more every year. We think we do a little bit better every year with all these things. So.
Well, I can see it over the years that I've been involved in this. People are living longer, and it's a great thing. Just like, yep, like Hal right over there, who's waving his hand.
Yeah, I've been doing this for 23 years now.
Amazing.
But I have a question. Would the standard 4 drug combinations have any effect on the viability of a skin graft after melanoma surgery?
I don't think it would. I don't know if we have any information on that, but I don't think it should. It shouldn't affect that sort of skin graft. I don't think so.
Dr. Zonder did have me stop therapy while I was having the surgery because, I've been having a big drop in my white cell count as a result of the therapy. So he stopped my therapy while I was having the surgery itself. I just wondered if I would need to continue to stop the therapy while I'm having the graft done.
Well, I think it might help the graft heal up if it allows your counts to recover a little bit. So it's more so a low count makes everything more difficult to heal up. So when the skin graft is put in, that's a nice time to let your counts recover a little bit. So it's not so much just a low counts make recovery a little bit harder for something like that. but they should be able to do it successfully. We do a lot of procedures on patients that go through therapy by stopping it for a little bit, let some of the side effects of the therapy resolve, let their counts recover a little bit, because that lets them get through some of the procedures much easier. Your white count and everything helps things heal up quite a bit, actually.
Well, it is 10:32, and that means our hour's up with our wonderful Dr. Uberti. We're really thankful that you can take the time to talk to everyone here. You have real specific information that I don't think that we can get anywhere else around here, and we are very thankful for that, for your time. And so if anybody has one last thing, but we really need to let the doctor go so he can get back to his work.
Thank you, Doctor.
Well, thank
you.
Thank all of you, and thank your foundation for doing such good work for everybody who has myeloma. It's really, I think, a godsend for all the patients with myeloma you interact with.
Well, we
Thank
appreciate
you for coming.
and everyone else. So I'm going to end this and say thanks to everyone, and we'll see you next time.
Thank you.
Take care.
Here.
Bye-bye.